quarter received cystectomy, 1 quarter received some form of chemotherapy or radiation. Now, I would argue in this period, it seems absurd to me that bladder cancer, muscle-invasive localized, should have a higher active surveillance or watchful waiting rate than low-risk prostate cancer. Yet that's what was happening in the United States. Something's wrong. So then more recent data, up to 2008, have shown that nothing has really changed. The blue is surveillance or no treatment, and that's still at approximately 50%. And as you can see, as patients reach age 90 and up, that increases. And maybe this is a reasonable number, but perhaps not reasonable in the 70 and 60-year-old category. So why is cystectomy underutilized? Well, we all know that it is associated with a significant morbidity and a significant mortality. This is a nice series from Memorial Sloan Kettering Cancer Center, over 1,100 patients. 64% of the patients had some form of complication, Clavian 2 to 5 in 83% of those. So it's not without its risk, cystectomy. A quarter of patients would require readmission, sent home, some form of complication, back to the hospital. We have very similar data at the University of Toronto, so nothing has changed much even across the border. The mortality rate is 1 to 6%, at Memorial 2.7%. Not too dissimilar to our rate, and an octogenarian 7 to 13%. So this may be why people are hesitant to pull the trigger for cystectomy. It may also be why patients do not want to undergo cystectomy, and it could explain that surveillance rate. What about quality of life after cystectomy? This is a series that looked at physical function, role function, and global function. I've highlighted for conduits, which are the most common diversion for cystectomy in North America. Global quality of life doesn't change too much, but there were significant decreases in physical and role quality of life. The post-operative recovery is long. There are long-term sexual, bowel, urinary implications. This study from San Diego looked at weight loss. And anyone who does radical cystectomy knows that when patients come back, they will have lost weight. The mean is approximately 20 pounds in the first month or two. They eventually will gain it back, but this demonstrates the catabolic phase that the patients go through. Weight loss may result from malnutrition, decreased PO intake, and thus complications can follow. So there is some significant short-term pain for this long-term gain. Because there is a long-term gain, there is cure. So this is where trimodal therapy may come in. As I mentioned, trimodal therapy is a combination of maximal TURBT, chemotherapy concomitant with radiotherapy. Now, before we start talking about this as an option for bladder cancer patients, there are two distinct groups that we have to think about for trimodal therapy. There are those who are simply unfit for surgery. Those may be some of those patients in that surveillance population that I mentioned. And rather than leave them with nothing, perhaps treating them with a non-invasive modality may be ideal. So trimodal therapy in this patient population allows us to treat more of these patients who are otherwise not seeing any treatment and destined to death. Trimodal therapy in a different population, however, can be used as an alternative to radical cystectomy, bladder preservation. This may allow patients to maintain their quality of life with the hope of not compromising their oncologic outcomes, and hopefully I'll be able to show you some of that data. I'll concentrate primarily in this group because in this group we've already said they're unfit for surgery, and it should be a no-brainer that we can at least offer them something in terms of treatment. So the ideal patients for bladder preservation at the University of Toronto, where we have this program ongoing for at least 20 years, but more established when Dr. Zlata was recruited in 2006, 2007, the ideal patients are those selected patients. I've written in bold and red, they're selected patients, it's not all patients. Tumors that are small, less than 5 centimeters, unifocal, no hydronephrosis, minimal to no CIS, good bladder function or capacity. Why do we want to save someone's bladder if they have nocturia times 7 and poor capacity? And finally, they have to be compliant with follow-up. You save someone's bladder, we can't let them go into the rural parts of Canada, thousands of kilometers away. They need to come for surveillance. So there's two different ways we can give trimodal therapy. This is the Massachusetts general approach, probably the most established approach, which is a split course. So patients have their maximal TURBT, the debulking TURBT. They undergo radiation, 40 gray with concurrent chemo, and then they're assessed midway with biopsies. If there is a complete response, they complete their radiation and concurrent chemo, and then they undergo surveillance. If there's an incomplete response, salvage cystectomy. I think part of this regimen of split dose was introduced because of the controversial nature of this therapy early on, and partly to appease the urologists. So this was devised by the radiation oncologists. We use a continuous course at Princess Margaret Cancer Center, where patients will get their full dose of radiotherapy. So 40 gray to the bladder and pelvis, a boost to the tumor, 24 to 26 gray, along with concomitant cisplatin, 40 milligrams per meter square. We don't actually do the biopsy afterwards. Many centers do, we don't. We rely on cystoscopy and cytology, and then patients undergo surveillance. If they have an incomplete response, then obviously cystectomy. And part of the reason we go with a continuous course is we would like the radiotherapy to have its full effect or opportunity to cure. We're not biopsying patients midway through their prostate cancer radiation, for example. So it wouldn't surprise me that you may have incomplete tumor kill rate midway through. So these are the Massachusetts General Hospital outcomes. Up to 2002, 350 patients, so a pretty good cohort of patients. 1/3 actually underwent a salvage cystectomy. And you can see on the left-hand side, this is disease-specific survival. On the right-hand side, overall survival. I've summarized them in this table. 5-year, 64% DSS, 10-year, 60%. So criticisms of this are, if the tumors are truly small, unifocal, 5-centimeter tumors, no hydro, no CIS, there's nothing adverse, these numbers actually don't look that great. I could do better with cystectomy. So why would I want to do this? Pooled data, there's no comparative head-to-head randomized trials. SPARE shut down early. Again, showed the same thing. Journal of Clinical Oncology, 2014, 5 and 10-year OS rates, 57 and 36%. DSS rates, 71 and 65%. I would have expected in a cystectomy cohort for this kind of selected patient population, 80% survival, disease-specific survival. So I don't think these papers actually support trimodal therapy. But a bit more information comes available in their updated series, and I think this can explain why. So now they're reporting in the more recent cohort, 2005 to 2013, the red lines. So those Kaplan-Meier's look much nicer. That's overall survival, disease-specific survival, bladder intact survival. The disease-specific survival is 84%. So that's what I would expect in a cystectomy cohort. The crude rate of cystectomy went down from over 30% down to 15%. So something is happening, something's improving. So what is happening? The older data were reporting patients with less selection. So those patients weren't necessarily the smaller tumors, 5 centimeters, T2. If you look closely, back in 86 and 95, many of them were T4, T3. A quarter had hydronephrosis, which most likely was a T3 tumor. Many had CIS. They weren't having complete resection of their TURs. Now look what happens in 2005 and 2013. They're learning from their experience. No one is at any higher than a T2. No one has zero have hydronephrosis. Very few, 20% only have carcinoma in situ, and they're resecting better at the TUR. So that would explain why we're getting results in the 85% survival, which is what we would expect with cystectomy, I believe. So now I want to review some of our data at the University of Toronto. So in 2008, we established this multidisciplinary bladder cancer clinic. So this is not necessarily prescriptive, but a guide to how one may want to introduce trimodal therapy. This was a referral-based clinic. Anyone can come. So we had non-muscle invasive patients, we had metastatic patients, but the goal of the clinic was trimodal radiation. So we had primarily localized muscle invasive disease. It allowed for a second opinion for complex bladder cancer cases. It allowed us to evaluate and at least offer to certain patients bladder preservation, which may not happen in some urologist's office. And it allowed for an interdisciplinary discussion. And what do I mean by that? All of our specialties were present. By all, I mean radiation and surgery. The consult is done at the same time. Both teams are in the room at the same time. One service is not, for example, saying negative things about the other service, which could happen in independent consultations. It's a collaborative group, and we have an open discussion with the patient and with each other before to say, do we think this patient is a good candidate, yes or no? And here, I think, is the most important part. You need to have a collegial relationship with the other team, so basically the radiation oncology team. The radiation oncologists in our group don't necessarily want to treat everyone. I was just in this clinic on Wednesday before I came, and of the 3 patients we had, 2 of them were felt to be not great candidates. And the radiation oncologist will tell that to the patient. So then they go towards cystectomy. Medical oncology was present in the clinic, but because we generally send for neoadjuvant chemotherapy, they weren't contributing as much as one would hope, or at least changing the decisions. So now they have we basically have an adjacent clinic at the same time. We can phone them up. So this is basically like an interdisciplinary tumor board occurring in the presence of the patient. And what we would do is discuss, do we need a pathology review? Do we need additional investigations, et cetera? So what are the advantages? As I mentioned, simultaneous assessment. Patients don't have to go to multiple sites. They're offered every treatment option that may be available, or at least a discussion on it. It's patient-friendly. Better communication between specialists, better collegiality between specialists, and a good review. There's 2 eyes at least, 2 medical doctors' eyes on all tests, so nothing will be missed. So this is, we have a research coordinator or a clinic coordinator that organizes the clinic in advance and summarizes all the data for us, so we're spoiled. We don't have to do that. And it's actually quite useful for these complex cases. The full history summarized as our 1-line synopses of every investigation, CT scan, cystoscopy. It helps us in follow-up too. So this patient received neoadjuvant chemotherapy, 4 cycles, these are the dates. Here was their chemoradiation, a total of 65 gray in this scenario. So this is our approach. They're seen in our clinic. Are they a trimodal therapy candidate? If they are, often we send for neoadjuvant chemotherapy. We think that should be the first step for muscle-invasive localized disease. And then we make a decision about which radical therapy they'll receive. If they choose trimodal therapy, debulking TURBT with Lipiodol injection, and I'll go over what that is. It's a thiodized oil used for lymphangiography. Then patients receive their radiation and their chemotherapy, and they go into surveillance. So this is the Lipiodol, small vial. It's 10 cc's. You probably only need 1 or 2 cc's to inject. And we inject this around the tumor site so that the radiation oncologist, when they're planning their dosing, can give a boost to that exact part of the bladder. Before we start this video, there's a small video. The very first slide is the radiation oncologist who is looking very happy in the OR with us while we're doing the Lipiodol, which demonstrates that they're very involved. So it's not like they're removed from the situation. We want them involved. It's very much like Botox. So anyone who's given Botox, it's this very similar approach. So if you could start the video. It's a series of slides. So I do this in the OR. This is from the 23rd, so just recently. We can do it under local too. So we've resected our tumor, we've debulked maximally, and now we're injecting Lipiodol. That's what it looks like. It looks like fat droplets. And here's where it most looks like the Botox injection. So nothing fancy, very straightforward. And this is what it looks like afterwards. You can see axial, sagittal, coronal views. This is the Lipiodol. You will get phone calls from your radiologist telling you that there's calcium in the bladder, which you can ignore. And that happened at least for the first 2 years. The radiation is planned according by the radiation oncologist, but they can boost this area. Here's more advanced planning, 7 beams IMRT. the nodes are always radiated as well. So this is the follow-up regimen. The follow-up regimen, in my opinion, should be very similar in terms of axial imaging to cystectomy, if not more frequent, because it may not be it's not considered as an established therapy. Plus, when you're going to evaluate your outcomes, you don't want to have discordant types of follow-ups. Patients are getting scoped every 3 months for 2 years, then every 6 months for the next 3 years, and then annually thereafter. They receive axial imaging at 3 months, CT or an MRI, and then at 6 months, 12, 6 months, 12, and then annually thereafter. So not very dissimilar to a cystectomy follow-up regimen. So there's an example of a patient post-neoadjuvant chemotherapy, but they come back, we scope them. Even on the scan, there's something there. There is a tumor there. We do a debulking procedure, TURBT. That was a TA high-grade tumor, and then that patient received the Lipiodol and then the radiation and chemo. Here's an example after trimodal therapy. After any bladder is irradiated, as you know, it does take a long time for the bladder to heal. So we're used to seeing this persist for even up to a year. Initially, we would resect everyone because if there was a suspicious area, we're worried. And as we started learning, these areas are simply just scar and healing. There's no tumor there. The cytologies are negative, so we've learned to watch those and get a bit better refined at identifying when there's recurrence. And over time, just like if you were to scope a patient who had hematuria 7 years after radiation for prostate cancer, we're all used to seeing what telangiectasia in the bladder look like. So in our clinic from 2008 to 2012, we saw 250 patients. The median age was 71. These are the characteristics of the patients, primarily muscle-invasive, localized. As I said, anyone could show up. So non-muscle invasives was 1/3, basically the BCG unresponsive population. Look who's referring to us. It's mainly urologists who don't really know what to do with the patient next, don't want to deal with the patient next, or want to offer trimodal therapy but don't have expertise to do it themselves. Many of the referrals are for second opinion. So then we looked at, are we actually doing anything of value in the clinic in terms of are we changing our decisions? So when we saw these 248 patients, we ordered additional investigations in about 80%. We didn't have to in about 20%. And these investigations were either a repeat procedure, TURBT, to get additional pathology, a pathology review or imaging. And then those investigations resulted in stage changes and then subsequent treatment changes. The problem with this kind of analysis is we don't have a control group. So we don't know if we're making the right decisions. We hope so because it's Princess Margaret Cancer Center. But that's one big limitation in interpreting these data. But when patients do come to see us, we're not relying exclusively on what they come with. We need to do additional investigations, as I'm sure many of you do. So ultimately, in summary, we had 83 changes in stage. So with our investigations, repeat imaging, TUR, 40% of patients did not come as billed in terms of their stage, clinical stage. That resulted in about a treatment change in about overall 1/3 of patients. And then in some situations, the treatment changes were just based on not necessarily needing additional investigations, but how the patient presented. This is the final distribution of how it didn't project as well of how patients were treated. 1/3 eventually did, or 30% did undergo cystectomy, but 1/3 underwent chemoradiation of some form. The clinic was very useful for a number of reasons. Not only were we able to offer trimodal therapy, but in terms of uptake of level 1 evidence, neoadjuvant chemotherapy. The SWOG 8710 randomized trial was published in 2003. There's good level 1 evidence for neoadjuvant chemotherapy, yet at the University of Toronto, not much was happening in terms of uptake of that modality. And once the clinic started, this is a time series, based on how we were doing, this is what the expected curve should have looked like, just a flat, straight line, but you can see it started to rise. So I attribute that to the fact that we have multiple disciplines involved, and it did increase our uptake or adoption of level 1 evidence in neoadjuvant chemotherapy. And so the lines in orange are the multidisciplinary bladder cancer clinic, and you can see the uptake in chemo was exponential. We even started to see it in the non-bladder cancer clinic, probably because it's the same urologist and the same working in both, but it just wasn't as high in terms of the rate of rise. We then compared our outcomes to cystectomy. We can't do that in a randomized fashion. So what we did was a propensity score analysis. All the other studies that I've shown you have been single series, so large case series from Mass General or pooled data of just this is how our radiation patients do, accept it and do with that as you will. But we want to see, are we actually doing any worse than cystectomy? If we were, maybe we would stop offering it or we would modify. Are we at least equal? So we matched on age, ECOG status, comorbidity, T stage, N stage, CIS, hydronephrosis, date of treatment. So basically all the big factors that one would want to match on. Of our trimodal therapy patients, 70% of them could have actually had cystectomy. They were good candidates. So these are not the unfit patients who have shown up in a wheelchair who are very poor ECOG. Table 1 shows very similar characteristics between the patients after matching. As I mentioned to the residents yesterday in our talk, after you propensity match, you should expect a very similar distribution, just like in a randomized trial. Overall deaths, 20 in the radical cystectomy group, 22 in the trimodal group. Deaths from bladder cancer are the same, 13. Small numbers, but still this was the first type of analysis of its kind. We probably treat 1 patient per month with trimodal, to give you a perspective. We had a DSS of 73% in the cystectomy group at 5 years and 76% in the trimodal therapy group, nowhere near statistically significant in terms of a difference. So Kaplan-Meiers for overall survival and the cumulative incidence functions were overlapping. So no difference that we could appreciate. On multivariate analysis, again, no difference. P-value is very high, so far from 0.05. Our salvage cystectomy rate is 11%. So similar to what Mass General is doing, maybe slightly better, but that's probably the number of patients where you'll have to actually pull the trigger and perform a cystectomy. What about recurrence then? So patients with cystectomy who recur are usually a localized versus systemic, but recurrence, but tough to treat. They have no opportunity, obviously, for a intravesical recurrence. So in our trimodal patients, we had a 60% recurrence rate. Now that may seem shocking, but 16 of those were systemic, which is basically equates to the radical cystectomy group. So if patients are going to fail distantly, they're going to fail distantly. So that brings us to the 17 intravesical recurrences, many of which we just managed because they're non-muscle invasive bladder cancer with TURs and intravesical immunotherapy. Those with muscle invasive recurrence go to cystectomy. And then what about toxicity then? We didn't report on toxicity. We don't have that data. Unfortunately, we did not collect it. But from the pooled analyses, grade 3 and higher complications, 6%. Grade 3 for GI was 2%. This was for GU. And is the cystectomy harder? It is. It's their post-radiation. This is, again, from Mass General. They sometimes will do the cystectomy early on, remember, mid-course. And that's what the immediate ones were versus later on. Those are recurrences. So 50 immediate and a 41 salvage, true salvage later on. And there was a higher complication rate. Immediate had higher cardiovascular hematologic, most likely because they've seen chemotherapy very early, the cystectomy is very close to the chemotherapy. And tissue healing may be an issue which was significant in the patients who had a delayed cystectomy. But we do know that that radiation does not help our tissues heal; it hinders. But that will apply to 10% of patients. I'm almost done. Quality of life, no great studies. This is a 7 or 10 year follow-up, single cross-sectional. So if you make it to 7 or 8 years or 9 years, then yes, your quality of life will be better with trimodal therapy, but that's because you are disease-free and you have your bladder. So it's a very selected population that's been sampled here. So I don't think we can really say right now what happens in terms of patients' quality of life. There haven't been good studies. A little warning on population-based data. There are a number of studies that have come out that have demonstrated that trimodal therapy does worse significantly than radical cystectomy. We wrote an editorial on that, And the problem with those kind of data is they're all administrative. We don't know what the indication for the cystectomy was. It could be that these are the unfit patients, so I would expect them to do worse. We have no data on the TURBT quality or on CIS or hydronephrosis, how the chemo was delivered, how the radiation was delivered. It's very granular, crude type data. So I don't know how much weight we can put on those studies, and I would encourage others to do studies like ours so we actually have a better idea. Now, one of the I guess criticisms of the trimodals is cherry picking, and I don't think that's a criticism, that's the truth. We are cherry picking. This is only good for 20% of the patients, in my opinion. 80% should be having a cystectomy, and these are the patients who we're cherry picking. So if you have a patient like that, then yeah, cherry pick, but don't offer it to everyone. And Twitter went crazy when our paper, maybe not crazy, maybe that's self-promoting. A few tweets came out suggesting that radiation is great for everyone, and that's wrong. That was not the purpose of the paper. I think we need to embrace multidisciplinary care. It's established in all these other cancer primaries, with demonstrated survival advantages. Uptake in bladder cancer has been relatively slow. My confession is I'm not a radiation oncologist, yet we do this. We think that, I still think that cystectomy is the gold standard, but we should discuss this option with patients. And as I said, 80% should not be receiving this if you look at the overall numbers, this type of therapy. This is the final slide. I think we should be open-minded about these treatments. Science and well-done comparative studies are better than dogma, obviously. And if you look at the evolution of cancer care, say breast cancer, colorectal, it started off with huge whacks, big operations, then combined modality therapy came, and then organ preservation. So why not in bladder cancer? So selected patients, that's the main conclusion. And this is a team from Toronto, in brackets, parentheses, are people who are no longer with us, Dr. Hermans, but who contributed it. Thank you.
Thank you, Girish, for this nice overview. Are there any questions? I have a question regarding the surveillance of these patients. If you say you mainly rely on cytology. How reliable is cytology? Because I have the impression that the pathologists are not always able to exactly say this is cancer-related and this is not cancer-related.
There is a lot of variability in the cytology. It depends on who your cytopathologist is as well. We rely on it, but have a low threshold for doing a biopsy or a repeat TUR.
And the healing after repeated TURs after radiation, is that a problem? Do you have patients where you see fistulas or something?
We have not had fistulas, but I have had patients with scarring and sloughing and yellow fibrosis. And every time you look in, it doesn't heal. And I've had patients where it takes 18 to 24 months for that to heal. Yeah. And if you go back and resect it, it's always just inflammation. Yeah. Dr. Sulzer.
Did you have to operate on patients due to the low bladder capacity then?
No, we have not had any toxicity-related cystectomies. It doesn't mean it won't happen, for sure. In some patients it will. I think it will be a low rate, but we probably have not had that many. We have about 80 or 90 patients in a 10-year span, so it will happen.
Okay.
Dr. Studer.
You see, that's why I never want to go to meetings anymore. I cannot shut up. So, listen, in your patients, almost everybody had a complete resection of the tumor. There was no tumor left anymore.
Correct.
So it was a complete TUR. We know from Harry Herr's series and others, I don't advocate it, but we cure some patients with a solitary, localized tumor in the bladder, which is completely removed. And I often tell the patient there's no need to take out the bladder with the normal tissue. So to which extent you look at natural history of disease, and to which extent did the additional toxic treatment help the patient? Because taking into account that most had been cured before radiation and chemotherapy, I think the results should even look better.
Well, with those small tumors in Harry Her's data, he doesn't have a 75-80% cure rate. I would say the cure rate is 10 to 20% in that group. So we still, you bring up the concept, I think, of the endoscopic positive margin. We don't know what's there, so we have to offer something in that scenario. So until we can figure that out. The same concept can be discussed with neoadjuvant chemotherapy. We have a PT0 rate of 25%, but who are going to be those 25%? We don't know, not yet, maybe one day, so that's why we offer cystectomy to everyone. Dr. Trimodal, you don't seem to like that answer.
Absolutely, but I'm going to go on that answer because what do you do when the patient is in complete remission after chemotherapy? Because when we look at the planning, one of the feature of your technique is the Lipiodol injection, and something which is also almost, I would say, a partial radiotherapy, because you don't take it doesn't seem that the whole bladder is in the field. So how do you plan the radiotherapy when there is no tumor left after the neoadjuvant radiotherapy? In such case, do you irradiate the whole bladder, or do you inject in the scar and you irradiate a certain lesion around the scar?
I don't think I was clear. So for all patients, they get full bladder. That's the 40 gray. And then the boost is to that Lipiodol area. And also in that 40 gray, we capture nodes. So the nodes are treated as well. Many of the pictures I showed are actually a photo capture system that we have. So we capture everyone along the way as well in terms of their tumor and its location. Sometimes you can't even tell where the scar is if it's a small tumor. Usually you can, and you would inject around the scar, but otherwise we go back and look at the photo.
It seems that today we have entered in the age of molecular diagnosis, having a couple of talks mentioning this during this session and these meetings. How do you deal with the recent subclassification with the sensitivity to neoadjuvant treatment regarding the 4 or 5 subclasses now?
Yeah, the luminal, basal, etc.
Yeah, luminal, basal, etc.
So we have not adopted anything that sophisticated. I don't know of any centers that are actually doing that and stratifying outside of research purposes. But it's interesting and something we've discussed, but we don't have a protocol for that.
Okay. Thank you very much.
Thank you.
Girish.